what do you believe if we start now? I will introduce you, Dr. Choi, in Portuguese to all the attendees of this meeting, and then we will start. What I mean, actually, is Dr. Choi was my professor when I lived in Korea for 1.5 years, and he was much more than a professor. I consider him an older brother. I learned a lot with him. I learned not only about endoscopic surgeries with him, not only about minimally invasive techniques. I've learned how to think about how to solve problems in spine surgery, how to think about the patient, how to prepare strategies to have the best result possible in other cases. So those learnings that I got with Dr. Choi, I take for all my life, and I try all the time to pass it and to teach my students as far as I can, to take this type of mentality, to mind of set, to think about all the problems, to think about the patient, to think about the best way to solve their problem. So I'm grateful to Dr. Choi that he helped me in my career. I've learned a lot of him, and I'm grateful that he is here with us this morning in Brazil and tonight in Korea. So I dedicate this wine to him. And thank you very much. Let's start with your presentation. Dr. Choi, tell us a little bit about your wine, please.
Okay, I will start. This is wine I brought. This is mainly Shiraz. It's made in the Chile. So this wine, last year, this wine got a winner of Divino 2019 Wine Style Award. It's not inexpensive. So usually it's 100 US dollar. So, but I really like this one. The Matetic is the owner, name of the owner. He has 7 or 8 variety of wine. Mostly name is EQ Shiraz or EQ Pinot Noir, EQ Cabernet. But he only used this wine under his name, Matetic. So I'm very like this wine. The best Chilean Shiraz. And today I will present about the anterior, percutaneous and anterior cervical discectomy. So percutaneous means on the local anesthesia, and approach anteriorly, and with the CM guide, and with the endoscopic guide, and with the patient response, we can do properly discectomy safely. Okay, so this is the animation. It's foramen herniation. We usually approach the contralateral side because contralateral side is easier and the patient will be comfortable. If we try to do the ipsilateral, we have to retract too much the trachea. Next, please. Next slide, David. Okay. This is just CM, and the left down, the right up. There is a ruptured herniation, but it's annular tear side. The herniation is bigger than the annular tear side. So in that region, we need to use the laser. Without laser, I don't recommend this surgery. So laser is essential. By using laser, side firing laser, we have to make the annular tear hole is bigger enoughly, and then we can take out the disc herniation. Next, please. So indication is only the soft disc herniation, mostly see 3, 4, 5, 5, 6, 6, 7. 7 is very difficult because we cannot see the lateral margin of vertebral body because of shoulder. So I don't recommend, but very thin patient is long neck patient. If you can see on the lateral view in operating room, if you see the C7 T1 level laterally, and then you can do. Next. It's video. Okay.
It's not, I believe it's.
Video, it doesn't work. The next. There's a many case of.
David, maybe he has to take a picture of the camera. Don't Choi service.
Can you show the video from your screen, Dr. Choi?
Okay, I'll try. 똑같은 거를 우리 비디오로. 시내 같은 거는 비디오인데.
Davi, aí quando tiver vídeo, a gente corta para ele e aí depois volta, entendeu?
뭐라고? 플레이 안 됩니다. 그러고 있어? 되는지 안 되는지 미리 확인했었어요. I'm sorry. It doesn't work even in my computer. That's a problem with the file. 밖에 나가면 동영상 있지 않아? PPT 파일 말고 뭐 전체 파일에 동영상이 있지 않아? 그거 말고 뭐가 이렇게 돼 있어? 내 거에 보면 동영상 파일이 이만큼 있는데 그게 다 같이 줘야지. 근데 동영상을 안 하고 지금 저 프레젠테이션만 옮겨오는 거잖아. 동영상 파일 그 안에 다 들어가 있어. Okay, let's go. I will show the video later.
Okay.
Next. 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 The 5, 6 left. Next. I do 100%. Let's check the CT scan because I want to know whether the herniation is calcified disc or not. If it's calcified, is not good indicate. So please check the CT scan before the operation. Next, please. Would you click just before this? work. 이쪽에서 클릭해라고. 오케이. 이거 보여줘, 이거. 다시 백하고.
Okay.
Okay, next. 나중에. 거기서 한 번 더 하는 거냐. Next.
Davi, desculpa,
Next, please.
compartilha a tela, Davi.
Next.
Next.
Next. Next. This is the patient. So recently I did the back. Please back. Back. Yes. So mainly she 5'6", right side, severe right arm pain and right arm weakness patient. And we checked the CT scan. Next. CT scan, mainly she has a minor OPLL, but it's not matter. Mostly it's soft disc herniation. So I decide to do the endoscope surgery. Actually, the patient is the nurse. Next. 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 The animation is most important thing by using 2-finger, carotid, and trachea. Mostly we don't need to worry about the esophagus because trachea and esophagus has a common very strong fascia. So just retract, push the trachea, and then esophagus always come accompany with the trachea. And just so you need to feel, try to feel the vertebral body by using your fingertip. The next. Discography first. Next. Insert of walking cannula and the obturator. Next. And position the working channel. So my recommendation is almost the same posterior vertebral body line until we recently we designed the new working channel. We made the thread. So just twist the working channel can advance by twist, not a hammering. So this is a good position, right side, almost the posterior vertebral body line. And next. This is a video click, please.
I'm trying here.
Okay, we can show all the video after my presentation. Okay, next. This is an important thing. This is on the local anesthesia. I remove herniation mass itself, and I saw the dura pulsation. My forceps is just very slightly, touch the dura, not compress. And I took a picture, CM lateral view. So this is not really dangerous because I can see the dura and the patient is awakened. So what I'm talking is, if your forceps is still inside of an intervertebral disc space, you never really remove the ruptured herniation. I already take this picture after removal of herniation. So I can see, I remove almost all the ruptured herniation. Next. This is a post-operative MRI, the nurse patient. She was very happy and she discharged the next day. This is an endoscope surgery. It's almost no scope. Next. I publish it. You can find this new progression, safe anterior endoscopic cervical discectomy technique. So try to find the journal, because it's a little bit different from previous journal, previous technique. Not hammering, just a twist. And so we can make a safe technique. Next. So the obturator and the working channel, end of there is a thread. Next. Not hammering. Next. Just if you twist, and then the cannula can advance. So it's a safe. Next. Next. Endoscope, cervical posterior foraminectomy. I think some of your colleagues is better than me, so I will skip this one. Now I will show the 3 of my video file by using my camera. David, would you change the screen, main screen? Yes. Okay. So this, 좀 클릭. 그거 말고 바깥에 나가서 클릭해도 돼. Insert of needle first, and indiocarmine injection, and guide wire, small skin incision, and obturator and working channel. Always by using the side firing laser, make a hole, widen, and removal of disc herniation. 또 동영상 있잖아, 또 동영상. 그 위에 거. 오케이, 그거 해. This is the video, the Saudi Arabian young man. Insert of needle until final obturate, insert of obturator. Keep your finger same position, push the trachea and the carotid. Discography, guide wire, and small skin incision about 3 millimeter, and insert of obturator. I am doing the hammering, but this hammering is previous version. Recently, we changed the cannula and working channel with the thread. It's a new version. And side firing laser, make an annular tear side hole is bigger, Napoli, and by using forceps, you can take out the ruptured herniation. After remove, we can see the dura. It's a post-operative MRI. axial view. Okay, I think I did, you saw all the presentation and video as well. So I'm very happy. I'm happy to hear some of the question from you.
Great presentation, Dr. Choi. Thank you very much. I would like to know from you, I know you don't like it so much, but do you have any idea or do you have any opinion regarding the posterior cervical foraminotomy? What do you think about it? Do you think it's the difference between the anterior and the posterior approach?
So posterior approach we can do. This posterior approach is almost the same as a microscopic or tubular retractor. So I don't think this is really better than this posterior endoscopic foraminotomy is better than the tubular retractor. I don't think. It's almost the same, because one thing is minimal invasive, but not really minimal invasive. Tubular retractor, small tubular retractor is a minimal invasive. So similar, but by using tubular retractor, we can decompress enoughly and safely. But it's depend on the doctor's experience. If the doctor is very much experienced with endoscopic posterior foraminotomy, I think it's good. But anterior cervical discectomy is totally different. Anterior cervical microscopic discectomy. Anterior endoscope discectomy is a really minimal invasive. We can make a patient almost normal. Open surgery, we cannot make a normal. Same as lumbar. Even we do very carefully the microscopic or tubular retractor, but it's even minimally, we have to cut the muscle and small ligament and capsular ligament and lamina. We have to touch the dura. But transforaminal endoscope, we almost never touch all the structure. So by using transforaminal endoscopic lumbar discectomy, doctor, we can make the patient almost normal. So it's the same idea as anterior cervical discectomy. Posterior cervical endoscopic discectomy and foraminotomy, it's good, but I don't think this is really better than the microscope or tubular retractor discectomy or foraminotomy.
Good. And regarding complications with the anterior approach, I believe most of our colleagues here in this meeting, and as far as I am, we are a little bit afraid because the features of our population, at least here in Brazil, we are a little bit more fatty. And I believe that it's quite a little bit difficult in some patients that have a thick neck to touch their anterior spine, the anterior body spine. So it makes the procedure sometimes a little bit dangerous, and maybe you can, during the puncture, to make an injury in the esophagus or maybe in the carotid. So what's your opinion, Dr. Choi? Did you anytime have any kind of these complications, and did you see these complications in your colleagues that they may occur?
So the possibility of complication, but in reality, we almost less than 1% complication because we are worried about. It's a disaster. So if you want to endoscope surgery, first try to palpate the patient finger before the surgery. If it is really comfortable and it is touchy the vertebral body, and then you can do. But if it is difficult to touch the vertebral body, if the patient is very short neck or very sick, I strongly don't recommend. It's contraindication. Don't do. This is a procedure, almost procedure, not a big surgery. Don't make a complication. So otherwise, second thing is I do always the local anesthesia. Some of the doctor, they do on the general anesthesia. Local anesthesia can avoid the complication because the patient is awake. Patient can the best monitor. If we touch any of small, the dura or root, patient immediately complain, my arm pain, my leg pain, so we can avoid. So if you follow my suggestion and very pay attention the patient response, and then I think it's not really dangerous.
Great. Dr. Choi, there is another question here from a friend, a colleague of us, Dr. Eloy Rosafa, and he asks about axial neck pain after surgery. Did you have any comparison? What do you see when you make the follow-up of your patients? Do they feel any kind of axial neck pain in the postoperative period, comparing with a CDF?
So actually, this endoscope surgery cannot compare the ACDF. If we compare the complication, regarding the complication, ACDF is almost 10 times happening, the complication, very much. But some of the doctors, they argue or criticize the after endoscope surgery, maybe disc space is collapsed and the actual leg pain. But we already have more than thousands cases review. The statistically, disc space is narrow, statistically, but it's not related with the patient, the neck pain. So this is not a really big surgery. We have to think that it's value, the endoscopic value. Don't do the same level comparison with the ACDF and PECD, endoscope surgery. This is almost a procedure. This is a really big surgery. But even this is a procedure, but it's really effective if you do properly. You already have seen the big herniation patient. The patient discharged just the 1 day after surgery. Very small scar.
Great, good. And do you have any consideration regarding the height of the disc space when you indicate the surgery for your patients? It's a question
Yes.
of Antonio Krieger, our friend.
Yes, because this is an endoscope surgery. The endoscope itself has a height. It's almost 5 millimeter, the outer diameter. So the disc space should more than 5. And if the disc space is narrow, it means most of the patient is some of bony foraminal stenosis or something. It's not good indicate. So one more, the back, the disc height collapse. So I always insert from the needle and obturator and cannula almost posteriorly, positioned posteriorly. During the advance, I use the conical shape of obturator. It means I never remove the central disc. Just to go with the conical shape of obturator through the disc space, but the central disc is beside. And just posteriorly, the docking, and try to remove herniation and remove. So I try to preserve the central disc. So, but statistically, we don't know actually if the patient is without surgery, already the degeneration is happening and it will be progress naturally, normally will be narrow the disc space. Even we didn't do the anterior endoscope surgery. Anyway, we review 1,000 cases. The disc space is a decrease, 10% or 15%, but it's not really related with neck pain.
Great.
Okay.
During your approach, did you have any kind of bleeding in the posterior annulus? And if it happens, how do you control it? Do you elevate? Do you increase the pressure of the water in during the surgery, or you use something bipolar?
It is a little different from the lumbar endoscope surgery. Anteriorly, it's almost no bleeding. But sometimes there is a small bleeding is the posterior annulus or the PLL area. We have a small size of the RF probe as well. So we can control endoscopically RF, but bleeding is very rarely. So don't worry about that.
Good. Do you have in any time have any kind of dural injury?
I don't have, but my colleague has one case of dural injury and some of weakness in the arm and weakness of leg.
Did it improve? He has to open
it? I don't know after then, but yeah. And we have another big complication is carotid artery injury. So the patient, before surgery, the patient had a thyroid operation, so scar. Anyway, he compressed the carotid artery until the ENT doctor is come there. So 3 hours or 4 hours, he continuously compressed, and we could save the life. Anyway, it could happen. So if the patient's the anterior surgery, don't do. It's good lesson. And always try to safely, if you approach by using your fingertip, is safely, and then do this endoscope procedure.
Thank you so much. So I would like to open for participants, for attendees, for their questions, their considerations. So okay. First, let's start with Marcus Serra, please. Okay. Tell us your opinions and your considerations.
Dr. Choi, it's very hard for us to talk some considerations when a guy with you are talking about endoscopic surgery. So I have a question. Are there any difference between anterior and posterior cervical scopes? The size of the scopes, what's the difference between them?
The size is quite different. Anterior approach, the scope is smaller size, very small. Posteriorly, so we have to mostly the foraminotomy and we need to drill, so it's bigger. The scope itself is quite different, mostly the size.
Okay, thank you.
Marco Moscatelli, do you have any question, any consideration regarding the presentation of Dr. Choi?
Yeah, Professor Choi, thank you very much one more time. Thank you for your patience and your time. We saw you enter the lateral of the disc and preserve the center of the disc. You told it, yeah. When as possible. But how many percent do you remove from the disc to go to the posterior side of the disc? Do you know?
I don't understand. Really.
You need to remove a little bit of the disc to go to the posterior part of the disc. Okay.
Yes.
Yes,
Only the posterior part. Only the posterior part. Only the ruptured part. I try to remove, but I approach it anteriorly, almost midline anteriorly. Start midline and read the angle for the target. So always before surgery to make a target, but start area is a midline. Midline anterior annulus, midline.
Okay. Okay. My concern is the anterioralization of the cervical. Yes, it's a problem for you when the cervical is rectification or anteriorization to do the anterior approach.
What, excuse me, what?
Like kyphosis, when you have any kind of kyphosis, you
yes.
need
When you have a kyphosis and the cervical kyphosis, okay, anteriorization of the cervical, it's a problem for you.
Are there any difference?
Do you contraindicate when the patient has the cervical kyphosis for the anterior approach?
Yeah.
No problem. Just the contraindication is kyphosis and lordosis. It doesn't matter. It's not a deformity surgery. We don't know the kyphosis is because of pain. Sometimes it's physiologically because of pain. There may be kyphosis. Previously, the nurse, it shows the kyphosis, but after surgery, the kyphosis is reduced. So just you need to evaluate disc height and if it is whether soft disc herniation or calcified disc herniation, and if it is a migrate disc herniation, is not good indication. So the kyphosis, lordosis, it doesn't matter.
And you need more than 3 millimeters to enter the disc. Okay, I saw in your paper. You need more 3 millimeters.
I think it's more than 5 millimeters. It's bigger.
Okay. Thank you. Thank you very much.
Welcome.
Anyone has any other question here? Facundo, do you have any consideration here regarding the presentation?
Thanks, David. Thank you, Dr. Choi. Thank you for your marvelous presentation. Thank you for being here. I know there's nearly 10 p.m. in Korea, so thank you for taking your time to being with us. And actually, I have two questions from the participants. The first one, I think the complication that we are most worried about is the carotid injury because of the consequences of the complication. And they were asking about locating the carotid and the ulnar with a ultrasound. Do you ever perform ultrasound to locate the carotid artery?
Actually, I have never experienced.
Oh, okay.
I think it's good idea, but I trust my finger always. My fingertip, you should feel the carotid pulsation by your finger. If you don't feel the carotid pulsation, and then I don't recommend the surgery. By using ultrasound, I think it's a good idea. Next time, if it's possible, I will try the portable small ultrasound may be helpful.
Okay, and another question about the recurrence rate, comparing the anterior and posterior approach. Do you know if the anterior approach has more recurrence rate?
It's my experience. The cervical disc is different from the lumbar disc condition. Lumbar, honestly, they maybe 10% or 15% is recurrent. But anterior cervical, very rare. The recurrent disc condition is very rare. We have some case after anterior endoscopic surgery. After then, consequently, we already done the ACDF cases. Mostly it's a foraminal problem, not a really recurrent. It's with the time to develop the foraminal stenosis, then we did the fusion ACDF. The answer, the recurrent is much less compared to the lumbar. I think less than 5% if you do the successfully remove.
I have a final question. You talk about the thick neck, about a contraindication for the anterior access, anterior endoscopic access, and you talk about this height as a condition to do the anterior endoscopic access. Do you have any more considerations regarding the contraindications of the anterior endoscopic access? Do you have any patient that you will choose to do an ACDF and not endoscopic access?
So indication is contraindication is different issue. So think the indication first. Indication, if it is not indicate, there is a contraindication. Indication, preserve the disc height and soft disc herniation, not migrated one, and level is from C4, 5, 5, 6, 6, 7. That is the indication. So otherwise, most of otherwise is you can think is contraindicated.
Ah, great. Thank you so much.
I have a question for Nicolas. Nicolas Prat is here, and he was your student as well, Dr. Choi, and the year before I went to Korea, and I would like to hear his considerations and and to know if he is performing the cervical endoscopy for cervical disease. So Nicolas, please, can you tell something about your experience in Colombia after you came back?
Hello, David. Thank you for your kind invitation. Hi, Dr. Choi. It's always a pleasure to see you. Actually, I'm not doing much anterior endoscopic cervical discectomy because of two reasons. The first one is I don't have that much patients with cervical disease to get enough training and ability to make this procedure. And the second one is that the equipment here is from my own property, so it's a big investment to make. And if you don't have that much cervical cases, then you will never pay for that investment. So those are the two indications why I'm not doing this type of surgery. I want to ask Dr. Choi when to choose PECD instead of a transcorporeal foraminotomy.
Soft discrimination. The transcorporeal is different issue. It's foraminal stenosis. If it is one side foraminal stenosis, I prefer the anterior foraminotomy, transcorporeal without fusion. But if it is a bilateral foraminal stenosis, I do ACDF. If it is a multi-level foraminal stenosis, I do the posterior foraminotomy. If the herniation is soft disc herniation, even the central or foramina not migrate, I do the anterior cervical discectomy. So the indication, it could be different for every doctor, according to the doctor's the philosophy and doctor's experience. So my recommendation is all of you, especially the young surgeon, you try to learn any kind of approach. If you can do anterior discectomy endoscopically, posterior endoscopic discectomy, transcorporeal foraminotomy, and then you can have many weapons to treat the patient. All the patient, every patient, they have the patient has the best option for surgery. It's depends on your experience. If you can do only the posterior foraminotomy, every patient you have to do the posterior foraminotomy. If you can do ACDF only, every patient you will recommend the patient ACDF. So just my recommendation is try to practice and learn any kind of procedure. If you can do, and then you can choose the best option for the patient. That is my message.
Okay, thank you very much. And I have one more question for
Okay.
you and for David. Maybe I know he's doing posterior foraminotomy. Is it possible to work in the posterior cervical spine with the transforaminal lumbar endoscope to make the posterior foraminotomy, or is too big to work there?
No. Yes. Sometimes I do the bigger scope. Bigger scope means the stenosis scope. I use the stenosis scope for the posterior foraminotomy endoscope. So by using transforaminal endoscope, lumbar transforaminal endoscope, you can use the posterior foraminotomy.
Yes, here in Brazil we have a problem with our currency. So when we have to bring the endoscopes from abroad, from Germany, from Korea, from wherever, it becomes very expensive, and so the companies and hospitals are not quite into taking many kinds of endoscopes. So actually we have here available the transforaminal, the interlaminar, and nowadays they are bringing, the companies here are bringing the stenosis systems, which have the wider working channels, right? But the cervical ones, it's not profitable for them yet to use, to bring them. So we have been using, I've been performing the cervical approach for 4 years, and we have been working with the transforaminal, first with the transforaminal endoscope, and nowadays with the interlaminar endoscopes, which are shorter, and they have good working channels, and moreover they have the width of the channel is good enough to introduce the drills. So we can use the drills to open and to make the foraminotomy, and it helps us a lot. So it's not a question of choice, it's the question of what we have available here in our country.
Okay, thank you very much. Good night, Dr. Choi. Thanks for your knowledge.
Thank you, Nicolas. Thank you for your
Dr.
consideration.
From
Thank you, David.
Colombia.
Marcus has another question.
Yes. Dr. Choi, a question. What's your criteria to decide if you enter anterior or posterior approach?
So one more, it's an indication. Anterior and posterior is an indication. So according to my experience and my knowledge, which option will be the best option for the patient? Every patient is different. So one more thing is my indication is anterior. If it is a soft disc herniation, relatively preserve the disc height, not the down migrate or migrate, and the level is good, and try to feel by hand. So thin patient and woman is already much better. And then I do anteriorly.
Okay, thank you.
Okay.
David?
Yes, the classical indication for the posterior foraminal approach, yes, is the same in the both endoscopic one and both the open foraminotomy, cervical foraminotomy, is that the problem has to be lateral, has to be foraminal. When you have a central disc herniation, or when we have a central stenosis, the foraminotomy won't help the patient by any instance. So if you have a soft disc herniation, lateral soft disc herniation, the posterior approach would be a great option to help the patients. And I've seen that even when we have hard disc herniations, even with calcified disc herniations, with osteophytes, we improve a lot. Maybe most of patients, I can say that over 95%, even we can't remove the hard disc herniation with the posterior approach. However, when we open, when we make a good foraminotomy, patients, most of them improve 100%. And maybe even when they have some kind of loosening of any kind of dystocia or hypoesthesia, they improve their sensitive symptoms. So I would like to hear your opinion regarding the posterior approach. When I mean with hard disc herniations with stenosis.
David and Dr. Choi, I think that the main problem in Brazil that we don't have anterior cervical scopes to make the procedure. So we have been performing endoscopic surgeries with one kind of scopes for lumbar. So we want to start to make an anterior approach, but it's impossible for us here because we don't have the scope to do this, okay? So it's an incredible presentation, but for us in Brazil, it's impossible to try this surgery because we don't have the device to do this. Maybe if some companies come to Brazil, cervical scopes, we can try to do this, but nowadays it's impossible for us. Can you understand, Dr. Choi?
Yes, there is a, I think that will be another issue or problem during my presentation or during the video presentation. The laser is mandatory. Definitely, without laser, you cannot do the anterior. Even you have an anterior scope, without laser, I don't recommend. So laser is maybe bigger problem compared to the scope itself. Laser is very expensive. So I don't know the available laser is there in Brazil, the laser.
Yeah, we have, but what do you think, Professor? We can do the procedure with a bipolar, like a trigger flex or a tube control. We can use the radio frequency bipolar.
Laser.
No. You should have the side firing laser, hormone YAG laser.
No, yeah.
So,
but you never use the bipolar. You never use the small bipolar and flexible.
Bipolar cannot make the annular hole. We have to remove, or we have to make a hole.
Yeah.
The rupture herniation is through the small hole, but its herniation is outside. It's bigger than the hole. So by using this side firing laser, we have to make a hole is bigger, and then we can take out. So without laser, just if you have the bipolar cannot make a hole bigger. So
yeah, you don't do you don't use the Carrinson to open these annulus. It's not possible for you.
Yes, but endoscope, the cannula, the working.
Oh, your endoscope is a little bit thin. Okay.
Yes, very small.
Okay.
So
yeah, very small. Okay.
It's impossible to introduce the drills inside the working channel.
No.
No, because it's different. There is one endoscope a little bit more large, when you can put the drill or bipolar and Carrinson, you can use this one.
Yes, that can be used as Western people, actually. The Korean, it's the Asian, it's very narrow space. We cannot use the big scope. If it is a big scope, the Wolf scope or the Joymax scope, their working channel is bigger. Then we can use the bipolar tip, but using the bipolar tip, we can control the bleeding or annular shrinkage, but we cannot make the annular tear side hole is make a bigger. It's not effective.
Okay.
So if you don't have the laser system, personally, I don't recommend.
Thank
you.
Dr. Choi, there are people that describe the technique, the endoscopic anterior approach, using and introducing cages in the disc space. What do you think about this technique? Do you think it is feasible? Do you think it is safe? If you, by instance, let's say that you have available, someone takes to you, Dr. Choi, we have a system, safe system to introduce cage through the endoscopic approach. Would you use it? What do you think about it? Would it be useful for your arsenal?
Excuse me, one more. I don't understand what you are
That's
asking.
wine
What is the point of your question?
Some people they say about through the anterior approach to the endoscopic approach, they introduce cages, cage the disc space. What do you believe? Is this feasible? Would you use one cage in your patients to prevent the kyphosis, the possible kyphosis?
Okay. I saw that Dr. Lim, Korean Dr. Lim, he did the ACDF by endoscopically, but it's not really endoscope. It's endoscope assisted. He did open surgery. He did almost open, but finally he took endoscope guide insert of the cage. But anyway, you asked me, I don't recommend. Just I don't think any advantage. Just a small incision, and this ACDF is one of a critical, very dangerous procedure. So safety is more important. Lumbar we may do, but cervical, the safety is very, very crucial. So just the endoscope or the really minimal invasive, I don't recommend. But if we make a strict, really good indicate for anterior endoscope cervical discectomy, and if you already have done many cases of practice and cadeva, and you have a knowledge, and then you can do. Endoscopically cage insertion, yes, okay. Just you can cheer, good job, but don't do.
Dr. Choi, regarding the cervical arthroplasty, the insertion of prosthesis, open arthroplasty, cervical. What do you think about this technique? Do you think it's minimally invasive? Do you consider it really a good option for young patients?
That is not really my specialty. But in a spine surgeon, still I'm doing the artificial disc sometime the fusion. So my indication of artificial disc is relatively young patient and not a really degenerative foraminal stenosis. Not degenerative means still almost intact posterior part of a facet joint. And if the patient has just one level or the other level already stopped the degeneration, we can think after fusion surgery, the degeneration will be accessory. In that case, I recommend patient to artificial disc replacement compared to the fusion surgery. But honestly say, I do the surgery much more than the artificial disc.
Good. Do you believe that there is any space in the future, maybe for the posterior approach for cervical stenosis in patients with lordosis? Do you think it would be possible feasible to perform a good decompression through the posterior approach?
Yes, I believe. It depends on the surgeon's technique, and maybe future what really the future is, maybe 5 or 10 years. But after 10 years, maybe some of artificial intelligence kind of robot not a really robot, but artificial intelligence, some of the machine, computer can assist the surgeon to more properly and safely the surgery. So if you say the future, the idea is artificial intelligence. Artificial intelligence guided something procedure, injection, something, any kind of things is they will navigate, they will teach it, they will guide, they will assist. So that is most of big issue of future.
Very nice, very nice. Thank you very much. So I would like to open for other participants here, if they have any other consideration. Marcos, Facundo, Moscatelli, do you have any final consideration? Marcão Serra.
No, it's very hard for us to talk something about Gunchor presentation because he's a history man, okay? And he's in our life. We follow all the knowledges of endoscopic surgery. But it's impossible to talk anything about the endoscopic surgery without thinking Choi. Thank you, Choi, for everything that you learned to us today. And I will talk to Marco Moscatelli to conclude the presentation, and Facundo and Davi. Thank you.
Moscatelli.
Thank you.
Your final considerations?
Yes, no more consideration about your lecture, Professor. Thank you very much. For us, maybe is we will have anterior cervical material in maybe 6 months or 1 year here in Brazil. But now is not possible for us. I use the interlaminar material to do a foraminotomy cervical, and discectomy and stenosis. Thank you for your knowledge. Thank you for your papers, your work. Thank you for your time. Maybe one day I will go to the Orindo, see you to do the surgeries. Thank you very much.
It's my pleasure. Anytime. Welcome.
Thank you.
Hopefully after this COVID pandemic.
Yes, perfect.
Sometime
perfect.
I will visit the Latin America. Maybe I think the next year there is the Colombia. There is a WFNS, the meeting, big meeting in Colombia next year. Maybe I will be there at that time. I may visit the Brazil as well.
Thank you. Yeah, yes, in Brazil, we did a congress, a world congress here in Brazil, a global spine here in Brazil, in Rio, maybe in the next year, I don't know.
Anyway, David, you did a good job, and even this the system is not really properly, but it's good to talk the face to face. It's good. And next time we can do this kind of meeting, but before meeting, if we test or prepare properly, and then I want to see some of the case and experience, and then I can advise or I can comment about that. So just I recommend the David regular base, very small size, but regular base with the wine is very good. Good idea.
Good idea. Thank you.
Let's
It's very good.
Continuously.
Thank you. Thank you. Thank you very much.
Thank you so much. I believe this is a great idea. Maybe we can make one meeting with each one of us, present one case, and we discuss which each other and with the participants and with the attendees of the meeting. Facundo, your final considerations, please.
Oh, thank you. Dr. Mucho, I already thank you about your presentation and about your knowledge, but also I had to thank you about your continuously pushing endoscopic surgery towards the future. And not only that, I think that in my experience, David was the one who told me everything I know about endoscopy, and you are the teacher of David. So I had to thank you about your teachings and your students, because they are really advancing endoscopy here in South America. So I have to thank for you about everything. And it would be a pleasure to have the possibility to show one of the cases that we do here in Argentina. It would be a pleasure and also a challenge, because you are with Choi and you will be seeing my cases. So it will be, I would be honored. Thank you. Thank you, David, and thank you all for having me here. It's been a pleasure.
So I would like to thank everybody who came to this meeting in the morning, here in the morning in South America, in the night in Korea. So I would like to thank Dr. Choi for his availability. We know that it's 10:30 in Korea, it's sleeping time, but it's Saturday. We never know what will happen on Saturday night. And we will thank you very much. And we are grateful to you, and we look forward to meet again in the future and to make this case discussion together.
Thank you.
Good. Thank you.
Take care, everybody.
Bye-bye.
Take care.
Bye. Thank you very much.
Cheers.
Cheers.
Cheers without wine. I become complete.
You run out.
And
You have
AM. I'm totally drunk. Yeah.
Let's keep drinking.
Yeah. Oh, there are.
it's almost noon.
Yes. Bye-bye, guys. Thank you very much.
Bye.
Bye-bye. Bye-bye for everybody. Thank you. Thank you, Dr. Choi.
Bye.